მოგესალმებით კოლეგებს, მეგობრებს, ვინც დარბაზში ბრძანდებით და მათ ვინც ონლაინ გვიყურებს Zoom-ის ან Facebook სტრიმის მეშვეობით. მადლობა იმისათვის, რომ ინტერესი გამოხატეთ ამ შედებთ ახალი, მაგრამ ძალიან საინტერესო თემის მიმართ და თემა არის კანაბისზე დაფუძნებული მედიკამენტების გამოყენება კლინიკურ პრაქტიკაში. ძალიან საინტერესო და მზარდი მიმართულება ბევრ განვითარებულ ქვეყანაში არის დაშვებული და კლინიკურ პრაქტიკაში გამოიყენება კანაბისზე დაფუძნებული მედიკამენტები სხვა ნოზოლოგიების თუ სიმპტომების სამკურნალოდ უამრავი კვლევა მიმდინარეობს დღეისათვის ერთ-ერთი წყაროს მიხედვით 600-ზე მეტი კლინიკური კვლევა მიმდინარეობს ამ მომენტში, რომელიც სხვა მიმართულებით იკვლევს და ამის თაობაზე ჩვენი სტუმარი უფრო მეტ ინფორმაციას მოგვაწვდის და ჩვენ გადავწყვიტეთ, რომ საქართველოში მედიკოსებისთვის, პაციენტებისთვის ეს თემა აგრეთვე ინტერესის საგანს წარმოადგენს და გადავწყვიტეთ, რომ დაგვეწყო ეს ინიციატივით გამოვედით საუკეთესო უცხოური პრაქტიკის გაზიარების შესაძლებლობა მიგვექცა, როგორც პროფესიონალებისთვის, ექიმებისთვის, აგრეთვე ფართე საზოგადოებისთვის. ეს შეხვედრა არის მედიკოსებზე გათვლილი და უფრო მეტად კლინიკურ ასპექტებზე იქნება საუბარი ამ მედიკამენტების გამოყენების. მე ბედნიერი ვარ, რომ აქ შესაძლებლობა წარვადგინო ჩვენი სტუმარი, პროფესორი Kirsten Müller-Vahl, რომელიც არის ჰანოვერის უნივერსიტეტის სამედიცინო სკოლის ფსიქიატრიის, სოციალური ფსიქიატრიის და ფსიქოთერაპიის პროფესორი. არის ასევე ნევროლოგიისა და დასრულთა ფსიქიატრიის სპეციალისტი, ტურეტის სინდრომის ამბულატორული დეპარტამენტის ხელმძღვანელი ჰანოვერში. კირსტენი არის კლინიცისტი და ამავდროულად კვლევარი და ერთ-ერთი წამყვანი სპეციალისტი ამ მიმართულებით. ტურეტის სინდრომის შემსწავლელი ევროპული საზოგადოების პრეზიდენტია. გარდა ამისა, იკავებს გერმანიის კანაბინოიდური მედიკამენტების ეროვნული და აგრეთვე საერთაშორისო ასოციაციის პრეზიდენტის თანამდებობას. 2017 წელს მიიღო კანაბინოიდური მედიცინის მედიკამენტების საერთაშორისო ასოციაციის ჯილდო კლინიკურ კვლევებში განსაკუთრებული მიღწევებისთვის კანაფის და კანაბინოიდების როგორც მედიკამენტების ხელახალი დანერგვის შესახებ. გამოქვეყნებული აქვს 160-ზე მეტი სამეცნიერო პუბლიკაცია, არის რამდენიმე წიგნის თანაავტორი, მათ შორის პირველი ავტორი გერმანული სახელმძღვანელოსი ტურეტის სინდრომის შესახებ, არის თანარედაქტორი სფეროსთვის მნიშვნელოვანი წიგნისა, რომელიც შეეხება კანაბისზე დაფუძნებულ მედიცინას. ეხლა კი გადავცემ სიტყვას ჩვენს სტუმარს. ჩვენი დღევანდელი შეხვედრის ფორმატი არის დაახლოებით 1 საათიანი მოხსენება პროფესორ Müller-Vahlis მიერ და შემდეგ გვაქვს დაახლოებით 1 საათი კითხვებისთვის, დისკუსიისთვის და მსჯელობისთვის.
Thank you very much for this very kind invitation. Yesterday I spent a lovely day here in your very nice city and I feel very much honored to be here today. So I was asked to give a kind of an overview about the topic of cannabis-based medicine, and as you have heard in this kind introduction, I'm handling cannabis-based medicine and caring for this topic now for more than 25 years. So I was a person who was involved in the whole process when cannabis-based medicine was legalized in Germany, and therefore I have a quite good overview about this topic. because I'm so much involved in this area. I also have some disclosures, as you can see here. So I received some honoria from scientific companies related to cannabis-based medicine for consultation and for giving all lectures. But I myself have the feeling that I'm completely independent. So in other words, I've never been employed at one of these companies. I want to give you an overview about the historical aspects briefly. Thereafter, I want to give you some introduction into the endocannabinoid system, because this is extremely important to understand how cannabis-based medicine works. Then we will discuss indications where cannabis-based medicine might be used. And then I will discuss some more clinical and more practical aspects, including how to dose cannabis-based medicine. We will discuss some side effects, contraindications, and interactions. So let's start with some historical remarks. So this is a picture from a pharmacy in Germany. It's a pharmacy that was active in the 18th century. And there you can see that at that time, cannabis was a well-established drug that was prescribed by medical doctors and that was offered by pharmacists. So it was absolutely normal at that time in many European countries that cannabis was used as a medication. This is a figure from bottles that came from a pharmaceutical company. The name is Merck. This company still exists in Germany. And at that time, at around 1900, they produced cannabis oils as illustrated here. So it was absolutely normal that we used cannabis as a medicine at that time. And then the situation changed dramatically, and this was related to different reasons. One reason is illustrated here. There was a kind of a cannabis prohibition. A lot of news came out about how dangerous cannabis may be. And in addition, new synthetic drugs were developed at that time. And because within cannabis, and I will show you this later, there are a lot of different ingredients. At that time, it was not possible to identify the chemical structures of all these different cannabinoids within cannabis. And these were different reasons why then the use of cannabinoids decreased, and this was accompanied by some laws, and in the end, the use of cannabis was completely forbidden in the US and also in Germany. To understand why cannabis-based medicine is useful, you have to know some basic aspects about this endocannabinoid system. It's a system that is located overall in our body. There are different receptors, cannabinoid receptors. The most well-studied cannabinoid receptors are the CB1 and the CB2 receptor. And there are also endogenous ligands that bind to these receptors. So in other words, this endocannabinoid system that was first detected about 30 years ago, so it was really a kind of a miracle that there's a receptor system, a transmitter system in our body that was not discovered so far. It was really a very important thing. This endocannabinoid system is very similar to other transmitter systems we have in our body. And besides these receptors, and there are not only the CB1 and the CB2 receptor, but also other receptors that are related to this system, we have these endogenous ligands, or they are called endocannabinoids. The most well-studied endocannabinoids are anandamide and 2-AG. And these endogenous ligands bind to the cannabinoid and cannabinoid-related receptors and activate this system. These cannabinoid receptors can be measured. You can use PET, and all what is illustrated here in red belongs to central CB1 receptors in our brain. And there are also some studies that illustrate that there are diseases, well-described diseases, where there's a change in this CB1 receptor binding in the brain. For example, this is in Huntington's disease, and there you can see the normal situation. This is how it looks in all of us. And here you can see a loss of CB1 receptor binding in the brain. This does not mean that this is the underlying cause of Huntington's disease, but it clearly illustrates that there is a change in receptor binding in this condition. And just yesterday in the evening, I read a paper about Parkinson's disease, and there a similar situation was found. So the authors described that in Parkinson's disease, the binding to CB1 receptors is decreased in the brain, and when levodopa drugs are used, the binding increases back to normal. And this is a really fascinating kind of research and very important to understand the underlying mechanisms of this endocannabinoid system. The opposite has been demonstrated as well. So here you see the normal situation. It's a little bit different, so don't be irritated because of the different coloring. And here you can see an upregulation of CB1 receptors in the brain, and this is in patients suffering from post-traumatic stress disorder. So there are other diseases where there's an upregulation and increase in receptor binding. Again, we do not know whether this is related to the underlying cause or it's a compensatory or a secondary mechanism. This is completely unknown. But you may speculate that there are diseases, well-described, well-known diseases, that are caused by a dysfunction in the endocannabinoid system. I already mentioned that the CB1 receptor is mainly located in the brain, but you can find CB1 receptors also in other systems. And the CB2 receptor is mainly located in immune cells, but only recently it was discovered that we also have CB2 receptors in our brain. And as mentioned already, there are other receptors related to this system, and we all know that there will be other further receptors, so far not described, that also belong to this complex system. There's a lot of research done in recent years to identify more detailed aspects related to this system. I don't want to go into detail, but what I would like to mention, it's known how endocannabinoids are synthesized. This is located in the postsynaptic neuron. Then they are released into the synaptic cleft, and they act at presynaptically located CB1 receptors. And then anandamide is degraded postsynaptically by this enzyme called FAR. And the second most important endocannabinoid, 2-HG, is degraded presynaptically by this lipase. It's called MEC lipase. So there's much known about this system now, and it's really fascinating how important this endocannabinoid system is for our well-being. And I would say it seems to be that you cannot survive without a well-functioning endocannabinoid system. You also can measure levels of endocannabinoids today. This is a figure you already have seen in post-traumatic stress disorder. And here they measured, in addition, levels of endocannabinoids. And as you can see here, the level of this endocannabinoid anandamide is reduced by 50% in these patients. And the opposite has been demonstrated by my group. We measured endocannabinoid levels in CSF, in cerebral spinal fluid, in patients suffering from Tourette syndrome, and we found a significant increase in CSF levels of all these different endocannabinoids. In addition, because so much is known about these different parts of the endocannabinoid system, not only the receptors and the enzymes and transport proteins, there are some companies who started to think about endocannabinoid modulators. So in other words, they developed substances that block these enzymes that degrade the endocannabinoids. And by blocking these enzymes, it's clear what happens. You block the degradation of, for example, 2-AG. The levels of 2-AG increase. And this means, in the end, an activation of cannabinoid receptors. So in parallel to our interest in using exocannabinoids, cannabis extracts, cannabis flowers, to stimulate the endocannabinoid system, there is increasing interest from pharmaceutical companies to develop new drugs. They are called endocannabinoid modulators to stimulate the endocannabinoid system by inhibiting the degradation or by inhibiting the reuptake. Those drugs are not in the clinics today, but they are already phase 1 and phase 2 studies initiated to investigate the safety and efficacy of this kind of drugs. So what kind of medication is currently available? And I will summarize not only the situation in Germany, but I would like to give you an overview about what is available worldwide. And this is summarized in this table. So this is what we have currently. And if you want to have an overview, you can group these different compounds. Let's start with THC compounds. THC, tetrahydrocannabinol, is the most psychoactive ingredient in cannabis. And there are drugs available that have only pure THC. It's also called dronabinol, so this is the same, dronabinol, tetrahydrocannabinol, and THC. It's all the same name for one and the same drug. And in addition, we have a synthetic THC analog. It's called Nabilon, and it's on the market in different countries under the name Canimis or Sesamet. And then in addition, we have products that contain pure CBD, cannabidiol. And there's one finished medicinal product on the market. It's called Epidiolex, and it's not 100%, but more or less only CBD. There's some discussion about this, and the company likes to sell this as a pure CBD contract, but in truth, there's a little bit of other cannabinoids in it. And then in addition, we have products that contain a combination of both THC and CBD plus other cannabinoids. And this is first the finished medicinal product Sativex, known as nabiximols. And then we have a huge number of other cannabis extracts and addition cannabis flowers that can be prescribed, at least in Germany, for medicinal use. And this was possible since 2017, when the cannabis law came into force in Germany. And after this, the market exploded. So we started with a very few numbers of flowers, and with this single finished medicinal product and cannabis extract Sativex. And now you can see we have more than 70 full spectrum extracts and more than 100 different cannabis strains that can be prescribed by medical doctors and available in pharmacies in Germany. Another way how you can classify or group these different cannabis-based medicines is first you can look whether these drugs are finished medicinal products. And finished medicinal products can be only on the market when they are officially licensed. So the companies have to show that these drugs are effective and safe, and therefore they have to perform large controlled trials, and an institute must judge on this data, and in the end these drugs are licensed, yes or no. And there are only 3 drugs that are officially licensed in Germany. This is this THC analog Canimis, it's this cannabis extract Sativex, and it's this pure CBD product Epidiolex. In the US, there are 2 THC products on the market. they can theoretically import it to other countries like Germany, but no one is doing this because there's no advantage. It's very cost intensive. But in the US, these products are officially licensed as finished medicinal products. And the majority of those drugs we use in Germany are not officially licensed, but they are prescription drugs. So when I prescribe cannabis-based medicine, besides Sativex, this is sometimes used, but I prescribe prescription drugs that are not officially licensed, but it's legal to prescribe it. And in some specific situations, health insurances also have to cover the cost for these prescription drugs. And this is dronabinol and all these full-spectrum extracts and all these flowers. And in addition, you can prescribe CBD. All these substances, besides CBD and Epidiolex, are under the narcotic drug law in Germany. So CBD is a drug that must be prescribed, but it's not under the narcotic drug law. But all the other substances, including all extracts and all cannabis strains, they belong to this narcotic drug. Why is it so important to differentiate THC and CBD? They belong to the same plant, to the cannabis plant, but and in addition, they have some action at the endocannabinoid system, but all other aspects are completely different. And this is important to realize. So in other words, THC is an agonist at CB1 and also at CB2 receptors. So in other words, THC stimulates CB1 receptors. And therefore, THC does not anything different compared to the endocannabinoids I explained in the beginning. So anandamide and THC also stimulate CB1 and CB2 receptors, and this is imitated by THC. So in other words, it's something your body is doing every day, permanently, and you can further stimulate this system by THC. And the action of CBD is completely different. This publication goes back to 2016, so it's now 6 years ago, and at that time it was unknown how CBD acts in this system because it was very difficult to identify the underlying mechanisms because it's very, very complex. And what we know today is that CBD indeed acts at cannabinoid receptors, but in addition, CBD has a complex interaction at several other neurotransmitter systems, including dopamine, including serotonin, including GABA. So it acts at several different parts compared to THC. And when we look at the action at the CB1 receptors and CB2 receptors, this is quite the opposite. I just explained that THC stimulates CB1 and CB2 receptors, and CBD blocks CB1 and CB2 receptors. It's not an antagonist, but it's an inverse agonist. But in the end, it's the same. So when you use CBD, you block cannabinoid receptors. But the situation is unfortunately a little bit more complex because in addition, CBD blocks the degradation of anandamide. So there's a little bit also in parallel is stimulation of this system. And this hopefully makes clear that CBD is a completely different compound compared to THC. These are the drugs I already mentioned, and I would like to give you some more details for these different drugs. So first we have those products that contain only THC. As mentioned before, we have this finished medicinal product, cannabis. In Germany, it does not play a major role because it's delivered in capsules, and one capsule contains 1 milligram nabilone, and this corresponds to 7 to 8 milligram dronabinol. And you never should start or initiate a treatment in a cannabis-naive patient with this dose because you would overdose him and it causes a lot of side effects. And this is the reason why this product, although it's officially licensed, does not play a major role in Germany. So when we want to use THC, pure THC. In most cases, we use this prescription drug, dronabinol, and as mentioned before, this finished medicinal product that is licensed in the US, called Marinol, does not play any role on the German market. Interestingly, Marinol was licensed in the US in 1985, so it's many, many years ago. And it was licensed for aid weight loss and for chemotherapy-induced nausea and vomiting. So some words to CBD, although this is not under the cannabis law and this is not under the narcotic drug law in Germany, but I want to mention it in addition. CBD is a cannabinoid without THC-like psychoactive effects. In a lot of publications, there's a relevant mistake because often it's said that CBD is not psychoactive, but this is completely wrong. CBD has some psychoactive effects. It has some psychoactive effects because, for example, we believe that CBD may reduce anxiety. And a drug that reduces anxiety, of course, has some psychoactive effects. But what people mean is that CBD does not have this THC-like psychotropic effects. And this is a difference that should be realized. I already mentioned that CBD is mainly prescribed as a prescription drug in Germany. And in addition, since 2019, we have this drug Epidiolex. It's officially licensed for rare diseases in rare conditions called Dravet syndrome, Lennox-Gastaut syndrome, and tuberous sclerosis complex. And there it's now officially licensed and used for the control of epilepsy. In Germany, it's licensed for children at age 10, but only in combination with another anti-epileptic drug. It's called clobazam. And then in addition, we have this finished medicinal product, nabiximols. I already mentioned it. And Sativex is licensed since 2011 in Germany. It's a sublingual spray. It's taken that way. And it's an extract that is standardized for the ratio of THC to CBD at a 1-to-1 ratio. So it's a balanced product. But in this extract, there's a lot of other cannabinoids, but these are not described. So we do not know the level of other cannabinoids in this compound. When this nabiximols spray came on the market and received the official license, the German drug law must be changed because at that time it was forbidden to prescribe cannabis-based medicine containing THC, and this caused some trouble. And therefore, we have a term that says it's the Sativex law that made it possible to prescribe this THC-containing drug in Germany. After the cannabis law came into force in 2017, the market exploded. So the first other full spectrum extract besides this Sativex spray that came on the market was this extract from a Canadian company called Tilray. But thereafter, many, many other companies decided to come with other extracts on the market, and this is nicely illustrated here. This is only the first page from 3 pages from one of the large German pharmacies who sell cannabis extracts. And when you try to make an order in this huge number of extracts, then you find for all of these extracts the ratio of THC to CBD. So there are products that are balanced, like this Sativex spray, having a ratio 1-to-1 or 10-to-10 or 25-to-25. So these are balanced products, similar to Sativex. And then we have CBD dominant extracts and THC dominant extracts. And this is what you have to realize when you want to select one of these extracts for the treatment of your patient. And then in addition, we are allowed since 2017 to prescribe cannabis flowers. Cannabis flowers, as mentioned in the beginning, contain several different cannabinoids, and these are numbers that are valid today, but all those people who are in this kind of research tell us that the number is still not the final number. So there are more than 100 different cannabinoids in cannabis plants. It's of course mainly THC and CBD, but there are several other cannabinoids that are today well known and well characterized. And in addition, you have more than 400 other ingredients that are non-cannabinoids. There's an intensive discussion also in Germany whether it's better to use such a dirty drug with more than 500 ingredients or whether to prefer pure drugs like pure THC and pure CBD. And currently we have to admit we do not know what's the best strategy. There's one hypothesis, this is called the entourage effect, and this entourage effect suggests that it's better to have this combination of different cannabinoids plus non-cannabinoid ingredients in cannabis-based medicine. So the idea behind this entourage effect is that the combination of different cannabinoids increases the efficacy of THC and reduces side effects. And there's in addition a hypothesis about an entourage effect that also relates to other ingredients like terpenes, and that the combination of cannabinoids plus terpenes in addition further increases the efficacy and the safety of pure THC. But this is a hypothesis, and it's not clear whether this is really true and whether this entourage effect indeed exists. But many patients and many doctors have the impression that indeed those compounds that include the whole spectrum of the cannabis plant are really more effective and better tolerated. So this is how it looks like when we prescribe in Germany cannabis flowers. We have to write the specific name here on the prescription, and then in addition, this is unfortunately an older figure. Now we are forced to write not only the total amount but also the daily doses and some other information on this prescription, and then we can decide whether patients receive bottles like this with the cannabis in it, or you also can decide that it's grinded in the pharmacy and then delivered to the patient. So we have two different options. We also can decide that patients receive, really as illustrated here, the whole plant, and they grind it at home with a grinder. As mentioned in the beginning, we have a huge number of different strains that are currently available in pharmacies in Germany from many, many different companies. And again, the system is the same. We have balanced products, we have THC dominant, and we have CBD dominant flowers. This is an older picture, comes from 2019, and the number of flowers was much lower compared to today. But in this figure, it's nicely illustrated what kind of different flowers we have. So in green, it's the level of THC, and in red, it's the level of CBD. And you see that most of the flowers available in German pharmacies are THC dominant. They have a level of about 20-25% of THC, and the highest level is 25% of THC in the flower. But we also have the opposite, CBD dominant flowers with a THC content of only 1%. Then, in addition, there's a controversial and intense discussion whether it makes any difference to prescribe sativa, indica, or hybrid strains. You may know this because recreational users also discuss this, whether you prefer a sativa or an indica cannabis strain. We have both in our pharmacies. and it's in most cases declared. But today we know that most of the strains that are available in our pharmacies are hybrids. So this means they contain both indica and sativa strains. Just to give you a background, what does it mean, indica and sativa? This does not automatically mean, although most people believe this, that they have different effects. But these names are simply from the form of the leaves. So the sativa strains look different compared to the indica strains. And it is absolutely unclear whether this also relates to different effects, although most of the patients, also my patients, believe that there's a difference in efficacy between sativa and indica strains. Some companies also declare the profiles of other ingredients like the terpenes. And this is illustrated here in this figure. They say and make clear what kind of terpenes are in their cannabis strains and what are the percentages. It's not really clear now whether this is important or not. So from my perspective, I would say it's a little bit a kind of a business. Patients are often interested in these terpene profiles, but I myself do not select a specific cannabis strain based on this terpene profile. It's absolutely unclear whether this makes any sense. And therefore, I do not like figures like this, because here companies promise that depending on the terpene profile, the cannabis strain has different effects. And this is really, honestly to say, this is nonsense. This is something that companies might speculate on, but it's not proven and demonstrated in human studies. So when you decide for a cannabis-based treatment using cannabis flowers, of course you should recommend, when you recommend an inhalation of cannabis flowers, you should recommend the use of a vaporizer. So in general, German doctors and hopefully doctors worldwide do not recommend to smoke cannabis. What's the difference? When you smoke, you inhale burned plant materials, and this is not good for your lung in any case. Independently from cannabis, it's also true when you smoke tobacco. And therefore you can decide to use a vaporizer, and therein cannabis flowers are not burned, but they are only heated. To heat cannabis flowers is important because you must decarboxylate THC acid to the active THC. So in other words, you can eat cannabis flowers and nothing will happen. This activation, or chemically spoken decarboxylation, is important. The THC is active as illustrated before. And therefore we have these two devices on the German market with a CE mark. But honestly, these devices, although used in medical treatments and covered by health insurances, these devices come from the recreational market. They are developed years ago, and there are a lot of companies who now want to develop new devices. This comes from a company in Israel. It's not on the market yet, but I'm absolutely sure that the situation will change, and we will have new devices that look a little bit more like medical devices compared to these more older devices. What is the difference when you inhale cannabis-based medicine compared to oral intake? There's a huge difference. You cannot say that one is better than the other one, but you have to know that there are huge differences. So in most cases, when we talk about inhaling cannabis-based medicine, then we are talking about cannabis flowers. But you also can take cannabis flowers orally. So, for example, you can make brownies, you can cook a tea. So there are also routes of intake, ways of intake for cannabis flowers for orally. And in contrast, mainly THC and cannabis extracts are taken orally, but there are also some ways to take THC as an inhalation. And only recently in Germany, a company came on the market. They are producing a cannabis extract that can be inhaled. So it's not 100% inhalation flowers and oral intake extracts, but there's also some differences. So what are the main differences between inhalation and oral intake? So first, it's the first onset of effects. When you inhale cannabinoids, then the effect starts within a few minutes, while after oral intake it takes relatively long. So I would say not 60 to 90, but 30 to 60 minutes, but it takes a while until the effect starts. Second, the peak effect is faster after inhalation compared to oral intake. And the third most important difference is that the duration of the effects is shorter after inhalation and longer after oral intake. And this is simply a difference. You cannot conclude that one is better than the other one, but it's an important difference you should know. This is the situation on the German market. And interestingly, those substances that are finished medicinal products does not play a major role in the German market. This is this amount here in gray. And the market is dominated by flowers in pink and by extracts in black. So in other words, this and the major amount of prescribed cannabis-based medicine in Germany are prescription drugs, and the finished medicinal products does not play a major role. And this is quite interesting because normally you would think, okay, it's an officially licensed drug and people would prefer this, but this is not true, at least in Germany. So let's come to indications. Where do we use cannabis-based medicines? As already mentioned, there are 3 compounds that are officially licensed. It's Sativex for the treatment of spasticity and multiple sclerosis. It's Canabis for the treatment of nausea and vomiting in chemotherapy. And it's Epidiolex for these rare epilepsy forms. And then in addition, in other countries, we have some differences. And therefore, I would say in these indications, it's also clear that cannabinoids are effective. So in addition, Marinol is licensed in the US for AIDS wasting syndrome and anorexia in HIV. And Sativex is also licensed for neuropathic pain and for pain related to tumor diseases. And therefore, I would conclude these are well-established and approved indications for the use of cannabis THC-containing medications. This is the first meta-analysis published on efficacy on cannabis-based medicine. It was published in 2015. And the result is this. Based on the publications at that time, the authors concluded there's moderate quality evidence that cannabinoids are effective in the treatment of pain and spasticity. We have heard about this. And they concluded that there's low quality evidence that in addition, cannabis-based medicine is effective in weight gain, in HIV infection, in sleep disorders, nausea and vomiting after chemotherapy, and Tourette syndrome. So what happened since 2015? In 2018, 3 years later, this publication came out from a group in the US, but there is no other indication. Tourette syndrome is now missing, but all other is the same. And this is a huge problem we have currently. So there's lack of well-designed controlled studies that really demonstrate that there is an efficacy in different indications. So besides these officially licensed substances, now it's clear that it's not only Sativex that is effective in the treatment of spasticity and multiple sclerosis, but also other THC-containing substances. And this is a Cochrane review published this year in 2022, and the authors concluded that there is indeed evidence that nabiximols, but also other cannabinoids, reduce spasticity in patients suffering from multiple sclerosis. So I would say there's no doubt about this indication. And again, there's no doubt about pain efficacy in treating pain. And this is a paper published already in 2018 by the European Pain Federation, and they concluded that cannabis-based medicine should be used as an alternative treatment in chronic neuropathic pain, but also in other pain conditions when there's no other therapeutic option available. This is a meta-analysis published only recently, and they investigated the effects of cannabinoids in different pain conditions. And they found first, indeed, cannabinoids, not only Marinol or Sativex, but in general, cannabinoids have an analgesic effect. And they also found that this is true in neuropathic pain, but also in neuropathic pain unrelated to multiple sclerosis. And they found the same, that this is also true in chronic non-cancer pain. So in other words, they conclude that cannabis-based medicine are effective in chronic tumor pain, in chronic non-tumor pain, and in chronic neuropathic pain, and in chronic non-neuropathic pain. And they found no difference in efficacy when comparing inhaled, oral, and oral mucosal administration. So in this publication, they tried to figure out whether the ratio of THC to CBD is important for treatment in pain. And what they found is the higher the THC content, the better the pain can be controlled. But in parallel, THC is also the compound that is most important for side effects. So CBD, there's an intensive discussion whether CBD has some pain effects. This is not really clear, but I would say based on data like this, it seems that THC is much more powerful in controlling pain compared to CBD. This is the situation in Germany, and therefore I have to apologize that this is in German language. But what is said here is this is data from Germany after the cannabis law came into force in 2017. And this nicely illustrates that in Germany, cannabis-based medicine are prescribed for pain in 73%. So this is the main indication currently in Germany why doctors prescribe cannabis-based medicine. Another indication that is not mentioned so far is palliative care. There's a general agreement that cannabis-based medicine might be helpful in this group of patients. And this is no surprise in my opinion, because we already mentioned that cannabinoids may reduce pain, they reduce spasticity, they improve sleep, they may improve the mood, they may reduce anxiety, they may stimulate the appetite, and all these effects are effects we would like to have in palliative care. And although there are studies missing, a lot of people are absolutely convinced that cannabis-based medicine has an important place in this group of patients. And the problem, and I mentioned it, is that we are missing controlled trials. And you may argue, I've seen such a lot of papers published in the recent years, but unfortunately, most of these papers are reviews. So they summarize the available data, and I also showed you some of these reviews, but what we are missing are controlled studies that produce new data. And this is really a pity, because without new data we cannot increase our current knowledge. By reviewing reviews, this may be of interest, but it does not help any further. And the main problem is that this kind of studies are extremely expensive. So in Germany, we calculate for a well-designed, large, randomized controlled trial about 3 to 4 million euros. So this is expensive. Pharmaceutical companies are not so much interested to invest this money. Most of the companies that are on the market in Germany are smaller startups. They tell me we do not have that much money. And another problem, because there are also larger companies where I would say, okay, they should have this money. Another problem is that cannabis cannot be patented. So compared to other new drugs, it's difficult for the companies, or this, of course, reduces their interest in supporting this kind of research. And unfortunately, also from the government side, the interest is not that much. This is a pity, and I would wish that the German government would invest more in this kind of research to bring our knowledge forward. So what about cannabis-based medicine in psychiatric disorders? There are 3 reviews now out. The first was published in Lancet Psychiatry, a high-impact journal, in 2019, and they concluded that the data is so insufficient that no conclusion can be drawn. The next systematic review was published 1 year later in 2020, and they called the evidence embryonic. So again, there's no data that you can conclude whether cannabis-based medicine is effective in psychiatric disorders. And the last meta-analysis was published last year. They identified 31 studies in the following indications: in cannabis use disorder, in schizophrenia, in opioid and tobacco use disorder, in anxiety, Tourette's, anorexia, and 1 trial each in ADHD, PTSD, and OCD. So it's a small number of studies, but in the end, they concluded the same. Although there is some limited data, the data cannot be used to conclude whether in these indications cannabis-based medicines are effective, yes or no. What is the reason when the database is so poor that we discuss about use of cannabis-based medicine in psychiatric disorders? This comes from real-world data. So in 2013, this first survey data were published. More than or nearly 1,000 patients in more than 30 countries participated in this online survey. And this is the answer patients gave why they use cannabis as a medicine. And when you circulate all those answers that belong to the spectrum of psychiatric disorders, then you can see more or less all diseases we are handling in psychiatry. So it's anxiety, it's depression, ADHD, autism, it's OCD, it's PTSD, Tourette's, sleeping disorders. So patients use it. And therefore, we have to decide whether it's useful, whether we should recommend it, yes or no. In 2020, the German Association for Cannabis-Based Medicine and the medical school where I'm working did a survey in Germany. We asked patients who have a prescription for cannabis flowers several different questions, and one question was, why do you use cannabis flowers? For which condition you mainly use this kind of medication? More than 1,000 patients participated only in Germany. And again, you see a long list of different indications where cannabis flowers are prescribed by doctors for these patients. And again, many of these different indications belong to the spectrum of psychiatric disorders. And when you zoom in, and I'm sorry this is in German, but I translated it, the top indication is ADHD, before different pain indications follow. And then it's PTSD, depression, sleep disorders, tic disorders, and anxiety disorders. So we know that although there's no database that really demonstrates that cannabis-based medicine is effective in the treatment of psychiatric disorders, patients use it, and medical doctors prescribe for these indications. And to give you an idea what data we have, let's focus in some of these different indications, and let's start with ADHD. So not only in Germany, worldwide, we know that patients use cannabis for the treatment of ADHD, whether it's prescribed by medical doctors or whether it's self-growth and whether patients make a self-medication. This is the database. There's one case series including 30 patients. This is from German doctors. And there's one small study including only 30 patients using Sativex in the treatment of adults with ADHD. The primary endpoint was missed, but in secondary endpoints, they found significant improvements in all those symptoms associated with ADHD. Another indication that is very controversial discussed is PTSD, and this is nicely expressed with the title of this editorial, whether cannabis is potentially effective in PTSD or it's simply snake oil. And there again is only one small trial in 10 patients. Here this THC analog nabilone is used, but in this study the authors found a significant improvement of PTSD symptoms. And all the rest of data comes from open, uncontrolled studies. In those studies, there are several hundred patients included. And for example, in this survey, patients reported that 50%, all the symptoms were reduced by cannabis by 50%. And they said it's not only anxiety, but also other symptoms that improved. But the author speculated that it might be that this is only an acute effect that does not last longer. But this is unclear currently. There are other reports, including hundreds of patients, where the patients report that several of those symptoms associated with PTSD improve after use of cannabis. But the discussion is controversial because there are also reports telling us the contrary. For example, in this survey, it's said that marijuana may increase suicidal thoughts and behavior in patients suffering from PTSD. And the same is reported here, that there's some deterioration in PTSD-related symptoms. Only recently, the systematic review only on PTSD was published, and the authors concluded that the majority of data supports use of cannabis-based medicine in PTSD patients, and they found that it improves not only sleeping problems, but also arousal disturbances, suicidal thoughts, pain, and overall improves patients' quality of life. Some further data in anxiety disorders. Again, the database is weak, but in some surveys it's reported that anxiety is the most often indication where patients use it. So it's THC-containing cannabinoids. And this is true not only for general anxiety disorder, but also for other anxiety disorders like social anxiety, anxiety related to depressive disorders, and so on and so on. There's also some data that CBD, pure CBD, might be useful in the treatment of anxiety disorders. And this is, there's some data for general anxiety disorder, social anxiety disorder, and anxiety related to PTSD. And the database, I can echo myself, is weak. And this is a small but nice study in patients suffering from social anxiety disorder, where it could be demonstrated that CBD reduces this specific subtype of anxiety. This is a kind of a stress test where symptoms increase in untreated patients, and after treatment with CBD, you cannot differentiate the patients from a control group. In depression, we have no single controlled study. We have some data from studies that investigate pain conditions or spasticity, where depression is a secondary endpoint, and there we learn that in these patients, cannabinoids may improve depression. But there's no single study that has been initiated to investigate depression as the primary endpoint. Again, we have reports from open uncontrolled studies. In this survey, nearly 2,000 patients participated, and they report a significant improvement of depressive symptoms after use of cannabinoids. And interestingly, the larger the percentage of THC, the better the effect was. Sleep disorders, the situation is similar to depression, no study at all, but we know from patients' reports and other studies in other indications that sleep may improve, and this is a systematic review only in sleep disorders, and the conclusion is as simple as that we do not have data to make any final judgment. There are two other rare diseases I would like to mention. It's autism spectrum disorder. This is important because we have no treatment at all for these patients, and most of these patients suffering from autism spectrum disorders are really, really severely ill. And therefore it's important to find new treatment strategies, and one of these strategies might be cannabis-based treatment. This is a study using pure CBD, open, uncontrolled, but parents reported about some symptom improvements. And this is the first controlled study, and interestingly, the effect was much better when you used not only CBD, but a combination of THC and CBD. This was a balanced product with the ratio of THC to CBD at 1:1. There was also an efficacy with a CBD dominant extract, but the effect was not that strong compared to this balanced product. In schizophrenia, we normally do not use THC because our belief is that THC may increase psychotic symptoms in this group of patients. But there's some data suggesting that pure CBD might be helpful. And this makes sense because I mentioned in the beginning that CBD does the contrary to THC at the CB1 receptors in our brain. And in this study, it suggested, it's a double-blind placebo-controlled trial, it suggested that CBD is similarly effective to a well-established antipsychotic called amisulprid. And this is another study where it is suggested that CBD is effective in schizophrenia, and here you can see in different measurements in psychotic symptoms that there's a clear and significant difference. So this is indeed an interesting finding, but we need more studies to find out whether pure CBD might be effective in schizophrenic patients. There's some discussion about cannabis in opioid abuse disorder. And this discussion was fueled by the opioid crisis. Luckily, we do not have this in Germany, but this is something that is a huge problem in the US. And therefore, it was discussed whether cannabis can be used as a kind of a substitute to treat patients suffering from opioid use disorder. And indeed, there's some data that this works and that cannabis cannot be used in opioid abuse or use disorder, but also in other kind of addictions like alcohol or addiction from other legal or illegal drugs. This is a study from my center, and as mentioned in the beginning, I'm an expert not only in cannabis, but also in tic disorders and Tourette syndrome, and therefore I'm very much interested in this specific indication. And this is the first large randomized controlled trials. We included nearly 100 patients and investigated the efficacy of nabiximols or Sativex in the treatment of this group of patients. And what we found, we missed our primary endpoint. This was defined as a responder criterion. But when you look at the data, we found that nearly 22% responded, defined on a tick reduction of 25%, and less than 10% in the placebo group responded. So Officially, we have to say we missed our primary endpoint because the p-value is above 0.05, but this is a clear trend towards efficacy, and this is supported by several secondary endpoints and secondary analysis where we found significant differences in tick reduction after nabiximols compared to placebo. And in 2 subgroups, we indeed found significant results, and this is also of interest. It was in the male patients and in patients with comorbid ADHD, and you should know that Tourette's is much more common in male, and ADHD is the most common psychiatric comorbidity in this group of patients, and therefore it's an interesting finding. In addition, we found a significant improvement in depression and a significant improvement in patients' quality of life. And this motivates us to continue with this kind of research in patients suffering from Tourette syndrome. What might be the reason why cannabinoids are effective in so many different diseases? So this is something we normally do not have. We have a drug that is developed and works in 1 or perhaps in 2 or 3 different conditions, but we do not have drugs that works in nearly everything. First, you may speculate it's only a placebo effect, but I would say we have now today enough data that this can be excluded. And there are different possible explanations. So the first explanation is that the endocannabinoid system is the most important neuromodulatory system in our brain. So in other words, stimulating the endocannabinoid system or modulating this system, you modulate in parallel all other neurotransmitter systems, including the GABAergic, glutamatergic, serotonergic, dopaminergic, and all these other systems. So you cannot avoid this. And this is a good explanation, at least in my opinion, why cannabinoids might be effective in so many different conditions. The second explanation might be that the endocannabinoid system is the most important stress regulation system in our body. And we know that most of the psychiatric disorders, but also other disorders, can be improved by reducing stress, or in other words, anxiety, depression, sleeping problems are deteriorate when you have more stress. And by reducing stress using cannabinoids, you may improve several different symptoms. And finally, and we already discussed this in the beginning, it might be that in some of the conditions we mentioned now, there is a deficiency or a dysfunction in the endocannabinoid system. And if this would be true, we could treat those patients who have a deficiency in their system with a cannabis-based treatment similar to the use of dopaminergic drugs in patients suffering from Parkinson's disease. Some words about neurological disorders. We already mentioned spasticity and multiple sclerosis, but there's also some evidence, and I mentioned it when I talked about the imaging of CB1 receptor systems. There's some idea that cannabinoids might be helpful in Parkinson's disease because there is a complex interaction between the endocannabinoid system and the dopaminergic system. And when we talk about movement disorders, you all have in mind these corticostriato-thalamocortical circuits in our basal ganglia. And these are very, very complex, and they are modulated by the endocannabinoid system. And where there's a blue circle, all these parts belong to the endocannabinoid system. And now you know that these basal ganglia circuits are heavily modulated and influenced by the endocannabinoid system. And when you try to sum these effects up, then this results in a reduction of motor activity. And this is something you want in patients suffering from hyperkinetic movement disorders. And therefore, there's some data, small trial, but here it's randomized, double-blind, placebo-controlled. Researchers could demonstrate that levodopa-induced dyskinesia can be reduced by using a THC compound. Another indication, what we found in our survey, is restless leg syndrome. It's known that a lot of people use it to improve these symptoms. And then there's an interesting discussion about potential neuroprotective effects of cannabinoids. So the effects on CB1 and CB2 and other cannabinoid receptors results in several different mechanisms that are important for neurodegeneration. And there's an intensive preclinical research about potential neuroprotective effects of different cannabinoids. And this results in speculations that cannabinoids might be effective in neurodegenerative disorders like Alzheimer's disease, Parkinson's disease, Huntington's disease, and amyotrophic lateral sclerosis. So there are some further indications we should mention. From our survey, once again, we have this very long list. And there's one interesting indication, it's inflammatory bowel disease. There's a few data suggesting that this may work. And when I should summarize other indications that I find interesting, this is this list, but it's definitely incomplete. But there are different conditions from all different subjects in medicine where we have heard positive effects, at least in single cases. So what about side effects? We know that cannabinoids may cause side effects. This is the meta-analysis I already showed to you. And they also looked at side effects. And they found that cannabinoids have more side effects compared to placebo. So this is not a surprise. But the most often side effects are dizziness, somnolence, dry mouth, and vertigo. And there's a good strategy how you can reduce the number of and the severity of these side effects, because these side effects occur early in the treatment and are mainly transient. And by slowly up-titrating cannabis-based medicine, we can reduce the number of side effects. And this is illustrated here. The blue, in blue it's shown when you up-titrate relatively quick, and in red when you do it more slowly, and you see all side effects are reduced. And therefore there's a general rule when you use cannabis-based medicine: start low and go slow. What about other side effects? We can look into the product information of Sativex. Dizziness and fatigue, again, it's mentioned as the most common side effects. Other side effects are mentioned, but I can tell you that most other side effects are not really relevant in clinical use when you follow this rule: start low, go slow, because then in the vast majority of patients you will not see other side effects, although they may occur. It's important to know that patients are some kind of regular users. You have the most side effects in irregular users. And when you use cannabis regularly, and this is exactly what our patients do, then you develop a tolerance. And interestingly, cognitive function is the domain showing the highest degree of tolerance. And this is why in patients where we use cannabis as a continued treatment, we do not see so many side effects. The acute toxicity of cannabis is extremely low. So there's not one single report in the literature where it's clearly described that someone died only because of intake of cannabis. There's no single report. And there's an estimation that you have to intake 750 kilograms of cannabis within 15 minutes if you want to die. And I would say this is impossible to do. So it's really a safe drug. There are some drug-drug interactions, and theoretically you can find this kind of long list, but practically this is not really important. For dronabinol, you have to know that there's some interaction with drugs that are metabolized by CYP2C9 and CYP3A4. But in clinical practice, you can combine THC with all other drugs. There's some information that you should be careful when there's a treatment with warfarin and when you use some specific kinds of chemotherapy, but in all other situations, you really can neglect the drug-drug interaction with THC compounds. The situation is a little bit different with CBD because, and I mentioned it, CBD acts at so many different neurotransmitter systems. The situation is more complex. You cannot know all this, but what you should know that there is an interaction with other anti-epileptic drugs, and when you use a high dosage CBD treatment, and high means 600, 800, 1000 milligram per day, then you have to know that there is an interaction with other anti-epileptic drugs. So my final remarks are, you definitely have to differentiate between recreational use and medical use. These are two completely different topics, and you should not mix it when you discuss about use of cannabis. Cannabis is without any doubt a potent drug, although it is misused by some people. But this is something we also accept with other potent medical drugs. So, for example, opioids, amphetamines, and other drugs. So I think this should not be a reason not to use cannabis as a medicine. In most cases, it's well tolerated. There's evidence that cannabis-based medicine is effective in a wide spectrum of many different diseases. And the risk for addiction is really low when you follow the rules I showed you. Start low, up-titrate slow, and then this kind of medication should be supervised by a medical doctor. So when you follow these rules, the risk for addiction is really, really negligible. But to bring us forward, we need further large randomized controlled trials so that we really know in which indications cannabis-based medicine is effective. Thank you for your attention.
დიდი მადლობა, კირსტენ, უაღრესად საინტერესო მოხსენებისთვის. ჩვენ გვაქვს დრო იმისათვის, რომ დავსვათ კითხვები, ვიმსჯელოთ. არის რამდენიმე კითხვა Zoom-ში შემოსული, რომელსაც მე ვითარნი და დავსვო. კირსტენს მანამდე მინდა დარბაზში ყოფებს კითხოთ თუ გვაქვს მიკროფონი. ბატონ სოსო, დიახ.
Okay, first of all, many thanks. It was really very interesting presentation, very deep and deeply explained all mechanisms and everything. I just developed several couple, let's say, questions. First is still regarding the addiction, regarding the drug abuse. Is there any strong evidences which shows what percentage can develop abuse, dependence? Let's say I'm representing oncology and palliative care. So let's say in palliative care for opioids, we are basing on a study which shows that in case of medical use of morphine, drug dependence is developing in 0.04%, let's say. It's a number. Is similar numbers here? Because regarding side effects, most of interest, I think, will be addressed on a abuse development, dependence development. Maybe. And I will ask second one. You introduced many positive effects of cannabinoids, and it was shown instead of placebo. But let's say for post-chemotherapy, nausea, vomiting, or pain, why cannabinoids, besides, let's say, other antiemetic drugs. Why cannabinoids beside the weak opioids? Is there any strong recommendations why we have to choose cannabinoids and not to choose other antiemetics, let's say, or for pain management, why cannabinoids and not, let's say, weak opioids?
Yes, thank you for your question. So the first question, in palliative care, I'm not an expert in this field of medicine, I have to admit, but I would say addiction is not the most important problem, I would say. And what I know from this area, we have in Germany a doctor who works in a private practice, and he is someone who cares for thousands of patients in this area, in palliative care, and he uses pure THC for many, many years now. And he published first data, and what he showed is that the amount of THC that is needed to improve different symptoms, including quality of life, is very, very low. So to give you numbers, he uses 2.5 or 5 or 7.5 milligram THC per day. And I would say when this is really true, there's no controlled data, but when this is really true, the dosage is so low that addiction does not play any role. Another aspect, in studies like the study I mentioned in Tourette patients, the study design is as follows. We treated patients for 13 weeks. We up-titrated for 4 weeks, and then we have had a maintenance phase for 9 weeks. So in total treatment for 13 weeks. Patients were allowed to up-titrate up to 12 puffs of Zativex, and this relates to 32.5 milligram THC. So it's a relatively high dosage. And at the end of the study, we do not down titrate, but we simply stop the medication because there's no problem. There are no effects after you stop this kind of medication.
There is no physical damage.
No, not at all. So this is what other researchers do as well. And in addition, people do not like to have dizziness, sedation after use of cannabis-based medicine. And when these side effects occur, patients stop up-titration or they even stop the medication. So those effects that are wanted by recreational users are judged as side effects in the context of medical use. So patients don't want to have these effects. And therefore, I would say, combined with the data that the risk of addiction is really low after use of cannabis, I have no single patient in this group of mainly Tourette and psychiatric disorders where I would say with the initiation of cannabis-based treatment, I initiated cannabis use disorder. We have some patients who self-medicated, and some patients have no access to legal cannabis or didn't have access to legal cannabis in the past, and they used street cannabis, and this is something we know. When patients self-medicate, they tend to up-titrate to higher dosages than we would recommend. And there are some patients in Germany who use medicinal cannabis, mainly cannabis flowers today. They use really large amounts of cannabis. And when I'm talking about large amounts, I'm talking about 4-5 grams per day. But I have one single patient, for example, he suffers from Tourette syndrome plus comorbid ADHD, and he told me that he uses 5 grams per day. So, and now he came to my office, asked me whether I can prescribe this. This cannabis treatment is reimbursed by his health insurances, and I hesitated a little bit. And then I made a suggestion to him that we make some driving tests under this medication. And what we were able to demonstrate is that his results in these driving tests were much better when he had used cannabis compared to the unmedicated situation. And this again makes me believe that we really treat a condition, that we improve the condition, and because he tolerates this kind of medication, after medication he performs better than without this medication. The second question, why do not use other drugs? I would say it's not either or, but cannabis-based medicine is another option you may take into consideration when treating patients suffering from nausea, suffering from pain. And we all know that there are patients who are treatment resistant when using our well-established medications. And therefore, I myself find it helpful to have another option that can be used in those patients who are treatment resistant or who do not tolerate all our well-established standard medications. It's not the question of either or.
Maybe can be another argument that, let's say, regarding chemotherapy, there is nausea vomiting, there is neuropathic pain, there is mood disturbance, cannabis can cover all these directions. This can be an argument. Besides the many different drugs, we can use one for all these directions. This can be a good argument.
Yeah, definitely. And I think this is also the strongest argument in palliative care, that you can reduce other drugs and that you can reduce, by reducing other drugs, reduce costs, and you also can reduce side effects. And ideally, you can use one drug and improve several different symptoms. This is an important argument, yes.
Thank you. First of all, I thank you for your very important presentation. Let me introduce myself. I'm Sofia Kasadze from Institute of Neurology and Neuropsychology. I'm an epileptologist and clinical electrophysiologist, so it's very interesting and very important, your presentation for me especially. ძალიან საინტერესო თემატიკაა და ძალიან მრავალმხრივი. ამ საკითხს ბევრი მხრიდან მიდგომა სჭირდება განსაკუთრებით ჩვენს ქვეყანაში, საქართველოში. იმიტომ რომ ჩვენ ძალიან დაინტერესებულები ვართ, რომ ეს საკითხი საკმაოდ აქტიურად იქნას წამოწეული ჯანდაცვის სისტემაში და საზოგადოებაში. თქვენ როგორც უკვე გამოცდილი ამ საკითხთან დაკავშირებით, საზოგადოებას ერთი განწყობა და ერთი დამოკიდებულება აქვს ამ საკითხისადმი და ჯანდაცვის სისტემას და ექიმთა კოლექტივს სხვანაირი, განსაკუთრებით მე ახლა აქ ეპილეფსიაზე ვსაუბრობ, იმიტომ რომ ჩვენთვის ძალიან მნიშვნელოვანია ამ პრეპარატებით მკურნალობის დანერგვა ეპილეფსიის ფარმაკორეზისტენტული ფორმების დროს და განსაკუთრებით ისეთი დაავადებების დროს და სინდრომების დროს, როგორც თქვენ დაასახელეთ ლენოქს-გასტოს სინდრომი და ასე შემდეგ. აი თქვენი გამოცდილებით ჩვენ საიდან უნდა დავიწყოთ, იმიტომ რომ ჩვენ არ გვაქვს თუნდაც ამ წამლის ადგილობრივად გამოყენების ესეთი აქტიური გამოცდილება. კი, ჩვენ ვკითხულობთ, ვიცით, მაგრამ თქვენს კარგად გესმით, რომ ადგილობრივად აუცილებელი არის გარკვეული ტრაილების წარმოება, რომ ჩვენ ეს დავნერგოთ და აქტიურად გამოვიყენოთ. ეს ერთი. მეორე მაინტერესებს ბევრი დაავადების სამკურნალო პრეპარატად გამოიყენება ეს წამლები და არის თუ არა განსხვავება დოზირებაში, მკურნალობის ხანგრძლივობაში და თითოეულ კონკრეტულ შემთხვევაში, თითოეული დაავადების შემთხვევაში როგორ უნდა დავიწყოთ მკურნალობა, რა დოზით უნდა ვმკურნალოთ, რა ხანგრძლივობით, როგორია ტიტრაციის საკითხები და ასე შემდეგ. და მაინტერესებს კიდევ აუგმენტაციის საკითხები აი ამ პრეპარატებით მკურნალობის დროს. კიდევ ერთხელ დიდი მადლობა, მინდა მოგახსენოთ, რომ ძალიან საინტერესო ინფორმაცია მოგვაწყდეთ.
Thanks a lot, and thank you very much for this important additional questions. So to start with your second question, how to initiate cannabis-based treatment. First, you have to decide whether you start a treatment with pure CBD. It's completely different compared to THC-containing drugs. Let's start with THC-containing drugs. So we normally suggest to start with a dosage of 2.5 milligram THC per day. And this relates to 1 puff of Sativex. 1 puff of Sativex, you cannot use half a puff, this is impossible. But 1 puff of Sativex contains 2.7 milligram THC. And on average, this is a good starting dose. I would use a lower dosage in children. I would use a lower dosage in severely ill patients at age 80 and above, in elderly patients, and in patients with polypharmacy. But on average, this is a good way to start. And then, as we have heard, you should up-titrate slowly, and this means I suggest to up-titrate by 2.5 milligram every 2 to 3 days. And depending on the specific situation,
3 days or per week?
I would say every 2 to 3 days. But there's no problem when you decide to make it a little bit more slowlier, and giving an information to a patient up-titrated once per week. It's of course always a little bit easier, so this is the most simple regime you can recommend to patients, and it's absolutely fine. So too slow is impossible. And when you recommend this regime, you always should add the information when the patient has some side effects like sedation, dizziness. He should go back 1 step, wait some days, and increase even slower. And this is I think, a good idea. On average, for THC, we have dosages in different conditions in Germany. I would say between 10 and 15 milligram THC. This is overall the average dosage. But we have some patients with much higher dosages, up to 30, 35, 40 milligram. And this is interestingly completely independent from the indication. And it seems to be also relatively independent from patient's age. So in Germany, we have a pediatrician who uses all kinds of cannabis-based medicine. And he says, I have some children where I see strong effects with 2.5 milligram THC, and in other children I use 30, 40 milligram, and they tolerate it very well. So it seems that the effects and the side effects are mainly independent from the specific indication and from the patient's age. But there is some evidence, this because I'm a psychiatrist, I would say in ADHD, most patients use relatively high dosages. And interestingly, most patients suffering from ADHD prefer inhalation, and then they prefer inhalation of cannabis flowers. And when I ask, why do you prefer this over other oral intake, they tell me the effect is much stronger without side effects. And I can better titrate it, because while inhaling, I feel the effect immediately, and I know when to stop inhaling. And in contrast, when I use an oral medication, I have to wait half an hour, 1 hour until I say, okay, the effect is okay or not. And when I then thereafter take another 10 drops of an oil or whatever, or another capsule, then it might happen that you overdose. And although in Germany, people who are a little bit more skeptical say cannabis flowers are not a good kind of administration, and they call it a kind of a dirty drug. We have a lot of patients who really prefer this kind of medication and this route of administration, for the reason I've mentioned. I already answered your first question in different indications, so I would say there's not really a difference when it comes to THC. When it comes to CBD, most effects are seen with high dosage CBD treatment. And this is important to know because I think it's the same in your country. You can buy CBD without any prescription in a lot of shops. And when you look at the CBD content in these bottles, it's very, very low. And based on the data we have currently, you cannot use this for any kind of treatment. And for Dravet syndrome or Lennox-Gastaut syndrome and tuberous sclerosis complex, this Epidiolex drug is licensed with a maximum dose of 25 milligram per day. So in other words, you can up-titrate depending on patient's weight up to 1,000 or even above milligram per day. And for all the indications I've mentioned, where we have at least low evidence that CBD is effective, we are talking about high-dose treatments. This means 400, 600, 800, 1,000 milligram per day. And the starting dose is in most of these cases around 100 milligram. In smaller children, depending on weight, even below.
Thank you very much for an interesting presentation, for the evidence you showed us. That was really interesting and fascinating. So my question is, we saw your presentation about the types of cannabinoids prescribed to patients. In majority of cases, these are flowers, then comes extracts, and the last one is finished pharmaceutical products. So the first question is, what is the policy regarding the prescription? Who decides? Medical doctor or medical doctor with patient in consultation? What type of cannabinoids should be prescribed to patient? And are there any kind of advices to patients regarding the mixing the flowers with the tobacco? And what are the probably some advices from the medical doctors to patients? Thank you.
So I would say it differs a little bit. And in my practice, and I think it's similar in all practices, at least in Germany, we have one group of patients who come into your practice asking specifically about cannabis-based treatment. And most of these patients are relatively well informed about this kind of treatment. And some of them already used it because they wanted to find out whether cannabis is effective, yes or no. And so in other words, some of them have used street cannabis, and when they felt that this is effective, they go to a doctor and ask for legalization and a prescription. So these well-informed patients often have an idea what they want to, because they are well informed. My argument is, when a patient found out that inhalation of cannabis flowers is effective in his condition, I see no reason why I should recommend oral intake of Sativex or THC, because the aim of my treatment is to improve the condition of the patient. And when he tells me this is what I already reached, I see no reason why I should make another suggestion. Some patients tell me, okay, this is effective, but I have problems to inhale, even if I use a vaporizer, to inhale cannabis at work, because people know what I'm doing there, because there's still some, you know what the patient is taking when you know how cannabis smells, and so then you can recommend another route of administration or another cannabis-based treatment. So the second group is patients who are not so well informed and who have never used cannabis recreationally or for self-treatment. And for these patients, most of the doctors, me included in Germany, recommend oral intake because it's much easier for a patient who is not used to use cannabis flowers. Because you must know some aspects how to use it. You have to know that you have to heat it, you have to smoke it, or you have to use a vaporizer. When you want to prepare edibles, you have to know how to do this, how long do you have to put your cannabis flowers into the oven, and how long you have to boil it with water, and that you have to put some cream in your tea so that you can after this use it. So there are some aspects you should know. And when you have no knowledge at all, I would recommend starting treatment with oral preparations, extracts or pure THC, and then see how it works. And thereafter you can discuss with your patient whether he has reached what he wanted or whether you should try in addition inhalation. So in other words, in most of my patients, it's a decision among the patient and me. I give some recommendations, but I try to leave this final decision by the patient. And your second question was, can you please repeat?
About mixing the cannabis with the tobacco.
So this is something I do not recommend. So patients who decide for smoking, this is nothing I recommend, but of course we know that some patients continue smoking cannabis. Then I recommend not to mix it with tobacco. And the reason is the risk for addiction is higher when smoking tobacco compared to smoking cannabis. And I know a lot of patients who informed me by starting inhaling cannabis, they were able to reduce or to stop smoking tobacco. And therefore I would recommend not to smoke tobacco or a mixture of both. But some patients doing this, yes, I know.
Thank you. And the last question, how it started in Germany, introduction of medical cannabis for medical doctors. Was it related with the implementation of the kind of national guidelines or protocols for specific field medical doctors, or what are the steps taken in Germany?
So I would say it started all with this cannabis law in 2017. And then some federations like the Pain Federation started to publish some guidelines or recommendations how to use cannabis-based medicine. Most of these federations argue against cannabis flowers, but I would say the main reason why they are doing so is that most doctors are not experienced with the use of cannabis flowers, and therefore they recommend not to use it. Sorry. Those doctors who have much experience with cannabis flowers feel that it's really an important other kind of administration, and it's not an either or. And then in Germany we have a lot of education, sometimes sponsored by pharmaceutical companies, but there's a lot of education, a lot of oral presentations online and in conferences about this topic, and this is, I think, the best way how to proceed. So to inform colleagues and medical doctors that we have a kind of a new medication that is effective and safe, and suggest to them to start using
it. Thank you, Kirsten. I guess we have 4 questions coming from Zoom. I'm not sure you are able to, provide expected response, because there are some really specific clinical questions. However, I will read them, okay? And then feel free to respond. The first one is, could you please advise treatment plan details for PTSD? what kind of prescription is most effective and can help improve symptoms? Thanks in advance.
Yeah, so as already mentioned, for PTSD we do not really know whether cannabinoids are effective. There is some ongoing research investigating whether pure CBD might be effective. We know that a lot of patients use cannabis and that they report that this improves their symptoms. So when I should start a treatment, I would follow the recommendation I just gave. When the patient used street cannabis before and reports it's effective, I would continue with this. I would ask the patient specifically, what have you used, how many grams per day, and how many intakes per day. And then you should know that street cannabis, at least in Germany, has normally a percentage of THC about among 15 to 20%. So normally it's a little bit lower compared to high percentage THC cannabis from the pharmacy. And this is an important information for your patient. When the patient never used cannabis, I would start with an extract. I would discuss, depending on the complete situation, to use a balanced product or THC dominant product, and I would use the dosages I just mentioned.
Thank you. Next question is about melanoma. If it's possible to use cannabis-based products for melanoma, for example, CBD.
I've never heard about this. So there's some discussion to use cannabinoids for treatment of tumors. There, for example, is some data that it might be helpful in glioma, in a brain tumor, but I've never heard about melanoma, but I have to admit I'm not an expert in this area.
Diabetes, what kind of cannabinoid is recommended for treating diabetes? And second question from the same author, if it's possible to use CBD oil before surgery for onco patients.
For diabetes, I'm not aware of any data. So when we are talking about reduction of glucose levels in the blood, you definitely can try to treat neuropathic pain related to pain. This might be an option, but then you do not treat diabetes, but you treat pain symptoms and other symptoms as we discussed already. CBD oil before an operation, I see no indication, and once again you must have an idea what is your target symptom you would like to improve. So in general I would see no indication to use it in general before an operation.
And the last question from Zoom. Thank you very much for a very interesting presentation. If you have any information about CBD use, CBD-based preparations, use of CBD-based preparations for treating marijuana use disorder.
There's no data I'm aware of treating cannabis use disorder with CBD, but there's some data suggesting that Sativex can be used for the treatment of cannabis use disorder. So to substitute cannabis flowers by a cannabis extract. This has been tried and there's some data that this may work. But I'm not aware about the use of pure CBD as a substitute.
Really well put together presentation. I just have a question about recreational marijuana use. So today in medicine we established that consuming, for example, 2 bottles of beer or 2 units of alcohol for a man per day is considered moderate drinking. what is considered moderate consumption of marijuana or cannabis per week or per day or etc.?
I would suggest to start a discussion about what is moderate amount of alcohol. So I would argue that there's no healthy amount of alcohol that can be taken. So each glass is one glass too much, so to be honest. But I think each individual can decide on how he or she wants to live. And we know that drugs play a role in every individual's life. And this is true for thousands of years in all different cultures. So it's more a definition by culture, what you should do and what you should not do. So I would say living without alcohol, living without tobacco, living without cannabis is the best way you should go. In addition, you should do some sports, you should not be obese, and all these different things. And we know all about this. Whether this is a happy life, you have to decide on your own. And we know that a lot of people like to use some so-called legal or illegal drugs. There's no clear definition what is a moderate cannabis use. There are some suggestions because for research this kind of classification is needed. So researchers like to group people, and therefore they try to define who is a moderate user and who is a heavy user. And although this is not really well established, I would say you are a moderate user when you use cannabis less than 1 or 2 times per week. And you are a heavy user when you use it more often. But this is only a more or less general rule. There's no strict rule. And then in addition, it depends on the amount of THC. Most street users do not know how much the THC content is in the street cannabis they use. And then in addition, it depends on how you inhale. So it's well known that most smokers who smoke cannabis are not really effective. So they puff it, and if you want to inhale a large amount of THC, you really have to know how to smoke it. And using a vaporizer is much more effective, because in the vaporizer your cannabis is not burned. In your joint, a significant amount of your cannabis is simply burned, and you have no chance to inhale it. So if you want to be most efficient, you should use a vaporizer, and then you can inhale a huge amount of THC.
There are a lot of modern efficient ways in smoking marijuana. It's not only like joints. There are different ways like they're coming up with. But my question was like, for example, you can drink like a glass of wine on a weekend and not worry so much about your health. Is there like, are we close to establishing like a measurement or like a meter for that for cannabis?
No, and this is completely different, and this is something what makes at least policemen and lawyers crazy in Germany, because they would like to have such a measurement. But this is completely different in cannabis compared to alcohol. In alcohol, you can measure the level of alcohol in the blood, and you can say the higher the level of alcohol in your blood, the more you are disturbed and influenced by alcohol. And this is absolutely clear, and therefore in most countries you have a strict level until which you are allowed to drive a car or to operate a machine and whatever. And this is not possible in cannabis. So the level of THC in your blood does not at all reflect your situation. And this is absolutely clear, and therefore it cannot be used for laws deciding about who is able to operate a machine or to drive a car. So we have seen patients with extremely high levels, and I've mentioned one of my patients. He used 5 grams cannabis per day. You can imagine his THC levels were extremely high, and his driving tests were absolutely fine.